Hello, I'm Lauren Haldeman, Editor-in-Chief of the Journal of Nutrition, Education, and Behavior, where we are advancing research, practice, and policy. Each month, we select an article to feature as a press release with an accompanying podcast. And today's podcast article can be read in full at www.jneb.org for free for the next 3 months. And today, I'm really excited to be speaking with Dr. Eliza Short, who is the corresponding author for the article titled Medically Tailored Grocery Delivery for Food Pantry Clients with Diabetes. I'm really glad to have you with us, Eliza. Can you tell us a little bit about yourself?
Yes, sure thing, and thank you for having me on today. So I'm a research scientist at the Center for Nutrition and Health Impact, and also a research collaborator with the University of Arkansas for Medical Sciences Institute for Community Health Innovation, where the study we will discuss today took place. So my research really spans from understanding the eating patterns of those with limited access to food or those who are experiencing food insecurity to the evaluation of programs that address both food insecurity and the prevention or management of chronic diet-related disease.
Great, thanks so much. So let's get right to it. Can you talk a little bit about the paper, including what you did, an idea of our results?
Yes. So this article presents the results of our intervention that was built and designed to address diabetes self-management within the context of food insecurity. So we recruited individuals from food pantries in Northwest Arkansas that had both type 2 diabetes and then also reported experiencing food insecurity. Individuals that were interested in participating in our intervention were enrolled and they received grocery boxes that were medically tailored to diabetes. And these grocery boxes were home delivered weekly for 12 weeks. In addition to those food boxes, they received recipes and a weekly education module focused on an aspect of diabetes self-management each week. So that includes things like healthy eating habits, physical activity, importance of taking diabetes medications, and so forth.
Great. Thanks very much. So as we think about the specifics of the study, can you walk us through the intervention your team developed? What was the approach and what made it unique?
Yeah. My colleagues at UAMS, they used a community engaged approach by convening community advisors. So this included people that were healthcare professionals, food bank staff, public health professionals, registered dietitians, certified diabetes education and care specialists, and community health workers, so many different disciplines to really carefully develop this 12-week intervention. And one of the unique aspects of this intervention and something that came to the forefront was the importance of including materials for English-speaking, Spanish-speaking, and Marshallese-speaking community members that are living in Northwest Arkansas and accessing food pantries. So the food and curriculum were designed and refined through stakeholder advisory board meetings, and then also went through a focus group process. So we had Spanish and Marshallese speaking staff that were recruited to kind of give their feedback and tell us, are these foods appropriate for Marshallese community members, for example, and make fine adjustments so that these boxes could be used in this intervention for a diverse set of individuals in Northwest Arkansas.
You had a pretty impressive team working on the development of this intervention. It's nice to hear about. So this was a single-arm study without a control group, and your article noted that participants' A1C levels improved from the start to the end of the intervention. Can you talk a little bit about how you can interpret these positive changes within the context of the study design?
Yeah, thanks for bringing that up. So one of our primary outcomes, like you mentioned, was the evaluation of hemoglobin A1C from baseline to post-intervention. And this is a measure and indicator of diabetes management. And so it's specifically someone's average blood sugar control over around a 3-month span. And so in thinking about this measure in the context of our study design, we had one group of individuals where everyone had the baseline and follow-up measurements, and then everyone received the intervention. So this means that we're not really able to determine whether improvements in A1C were due to maybe the food provided versus the education components of the intervention, or maybe it was a combination of the two. And this, we would be able to determine if we had multiple groups kind of flowing through this intervention. But I do want to note the importance of the statistically significant change in A1C, but that it was also clinically meaningful. So it was around 0.56%, which is a magnitude that really is important for reducing down the road complications that really can stem from poorly controlled diabetes.
Nice, and that clinical importance, clinical significance is really important. I want to actually jump to the dietary quality piece as well. So when it came to the diet quality, you didn't really see major changes. What do you think contributed to that? Did you explore anything else related to eating behaviors or nutrition?
Yeah, we did. There's a couple of different factors that could have contributed to the lack of change. And I first want to talk a little bit about how we collected dietary intake measures and then the measure that we used. So we collected dietary recalls, and what that means is we called individuals at baseline and at follow-up and asked everything they ate in the previous day. And so this allowed us to get kind of a general understanding of what were people eating at the start of the intervention, and then what were people eating at the end of the intervention. And then after we got all of that dietary intake data, we were able to apply it to the measure called the Healthy Eating Index. And what this measure is it's able to look at that group of foods and compare it to the dietary guideline for American recommendations. So those recommendations state things like eating saying that half of our fruits and vegetables should make up our plate at each meal, for example. So because we used a measure that takes into consideration fruits and vegetables, whole grains, and every aspect of our diet, we are able to capture someone's entire eating pattern as a whole, which is a benefit. But then it can also make it challenging to understand whether or not the intervention impacted any individual component of dietary intake, because some of the components may have increased due to the intervention. Because we had many fruits and vegetables in the food package, we may have had increases in fruits and vegetables, but other aspects of diet quality that went into that healthy eating index could have been decreased or maybe not changed at all, which could offset any net changes. And then the second aspect I wanted to bring up that's really important for future researchers to think about is the timing of measurements. So our post or follow-up dietary recalls were collected up until 8 weeks after the food deliveries were completed. So this means that by the time we assess diet quality, participants could have experienced a short-term change or bump in diet quality during the intervention that dissipated once the intervention or the food ended. So I've noticed a lot of recent studies describing the same challenge, and I really recommend that future researchers think about maybe assessing diet quality during the intervention or during the food delivery portion to understand how are eating patterns changing when someone is actually consuming that food.
So you've learned a lot of lessons for future research. But my next question for you is, what lessons from the study did you learn that really could inform food as medicine programs in real world settings?
Yeah, that's a great question. And the first lesson I was thinking about it takes us back to kind of one of the primary goals of this study was to reduce barriers that make it challenging to participate in interventions like this, and really carefully designing interventions that will enhance engagement. So in our study, we were able to partner with DoorDash and have a home delivery of food, but that's not always feasible for all individuals implementing programs like these. But thinking through what other things can help engagement. So for example, there could be an option for participants who have transportation barriers to receive vouchers and have transportation kind of facilitated for them to food pickup sites. Or maybe for education, it could include a tailored one-on-one session with a registered dietitian, for example, to enhance engagement with education resources. Yeah.
Thanks. That engagement piece is so critical, and I'm glad that you were able to discuss some of those lessons learned and how these types of programs can be improved upon. Eliza, thanks so much for spending this time with me. Before we go, though, is there anything else that you'd like to mention?
Yes, thank you so much for having me. I would also love to take the moment to acknowledge our partners in this intervention. We had Harp's Food Store in Northwest Arkansas that supplied the food and allowed us to come and pack the boxes each week. And then we partnered with United Way of Northwest Arkansas and DoorDash's Project Dash for their help in delivering the intervention to those participants. And then I'd also love to thank all of my UAMS colleagues and the Community Advisory Board members for their feedback and work through developing, implementing, and refining and disseminating the study findings. And then lastly, I just wanted to put in a plug that if anyone is looking for diabetes self-management education resources, we do love to share what we have developed, and you can find more information in the link that will be a part of this podcast.
Great. Thanks very much for directing us to that link. And again, to all of our listeners, remember you can read this article in full at www.jneb.org for free for the next 3 months.